Good afternoon and welcome. I'm Dr. Cheryl Hilton, Dean of NYU's School of Global Public Health. We're grateful to have you join us today for one of our ongoing GPH anti-racism thought leader discussions. I'd especially like to thank our co-hosts, the NYU Brademas Center and DC Dialogues. First, some brief housekeeping issues. We'll be recording this session for those who are unable to join us today. In addition, at the end of this afternoon's session, our panelists hope to answer questions from the audience. You may submit your questions at any time using the Q&A function. Time permitting, our panelists will aim to review and answer as many of these as possible. Now on to our program. As of 2 weeks ago, the World Health Organization reported approximately 7 million COVID-19 vaccine doses had been given in Africa. Cumulatively, over 25 million doses of COVID-19 vaccines have been received in 38 African countries. 38 African countries, 30 of which have begun vaccination campaigns. Today, we explore the many ways in which much more remains to be done to ensure that Africans, many of whom have previously been subjects in vaccine trials, are in line to benefit and benefit thoroughly. At the current rate, these countries won't reach 60% vaccine coverage until 2023 or beyond, an unacceptable reality. To lead this timely discussion, it's a pleasure now to introduce Nigerian-American writer and journalist, Professor Frankie Edozian. Professor Edozian directed the New York University Journalism Institute Ghana-based Reporting Africa program from 2008 to 2019, and currently is director of New York University, Accra. Please join me in welcoming Professor Edozian.
Thank you so much, Dean Hilton. Thank you very much for all that you've done in bringing all of us here together. Thank you so much, everybody, for joining in, and NYU DC and the Brademas Center for this wonderful discussion that we are about to have. We have a stellar group of scholars with us, but it's very interesting that we're at a time where all we can think about and all the world can talk about is vaccines and what we're going to do with moving forward with COVID-19. I remember at the onset of all of this, almost a year ago, experts in Europe were talking about how it would be better to do all the testing and all the trials in Africa because it seemed as if the continent was a place where we could be used as a testing ground. You know, some people were offended by the idea of using Africans as guinea pigs for something that was happening the world over. But in the years since COVID-19, inequalities have been shown to be the world over when it comes to treatment. What has the world been through? Nothing like this. In recent years, we've talked about Ebola, we've looked at HIV, we've talked about H1N1, but there has been nothing that has brought the world almost to its knees the way COVID-19 has in recent time. And so what are we going to get out of the myths and the realities of a vaccine and the post-colonial global health? We know right now that in sub-Saharan Africa and in many parts of the world, you cannot travel unless you have a yellow fever vaccine. How does that impact going forward? Will the rest of the continent or will all of us continue to just try to get vaccines? What about vaccine hesitancy? What about all of the people who are feeling like they have given so much to science, but are getting little back? We have an amazing panel of experts who are going to discuss this, and then we're very happy to take questions afterwards. And I'll do a brief introduction before we all begin. First and foremost, we're going to, I'd love to introduce Dr. Holly Hagen, who is a professor in the Department of Social, Behavioral Sciences and Epidemiology here at the NYU School of Global Public Health. She has been trained as an infectious disease epidemiologist, and her work has sought to understand the causes and consequences of substance use disorders. Her research has examined blood-borne and sexually transmitted infections among people who use drugs. She's an internationally recognized expert in etiology, epidemiology, natural history, prevention, and treatment of hepatitis C virus infection among people who use drugs. Dr. Hagen served on the Institute of Medicine's Committee on the Prevention of the Control of Viral Hepatitis in the United States. And one of the things that she's going to talk to us about is to give us an idea of how HIV and AIDS and the treatment for that dovetails into what we're going to see with COVID-19 going forward. So please welcome Dr. Hagen. Our other panelist today is the first of our Matts, Dr. Matthew Kavanaugh. He works at the intersection of global health, politics, law at Georgetown University. He is a political scientist by training with a long history of work in global health policy and politics. His research and writing focuses on the political economy of health policy in low and middle income countries and the political impact of human and constitutional rights on population health. He has done research and policy work in South Africa, Malawi, Haiti, Lesotho, India, and Thailand, and is a visiting researcher at the South African Institute for Advanced Constitutional, Public Human Rights, and International Law in Johannesburg. Our other Matthew with us today is Dr. Matthew Liao, who is the director of the Center for Bioethics here at the School of Global Public Health. Dr. Liao uses the tools of philosophy to study and examine the ramifications of novel biomedical innovations. A speaker at TEDxCern, Dr. Liao discussed whether it is ethical for someone to erase certain aspects of their memories and how doing so might affect that individual's identity. He has given a TED talk in New York and has been featured in the New York Times among many other publications. He is an author and editor of 4 books. In one of his collections, The Right to Be Loved, he explores the philosophical foundations underpinning children's right to be loved and proposes that we reconceptualize our policies concerning adoption so that individuals who are not romantically linked can co-adopt a child together. And finally, my colleague from NYU Accra, Dr. Kojo Senna. Dr. Senna is currently an associate professor with the Department of Sociology at the University of Ghana and an adjunct professor with the Central University College Ghana, where he teaches undergraduate and graduate courses. One of the wonderful things about Dr. Senna is that he's able to bring up traditional healing methods, traditional African healing methods, and merge that with biological sciences in a way that our students and our researchers have always been able to understand. His areas of academic and research interest are medical sociology, anthropology, criminology, penology, rural sociology, rural development, and urban sociology. And he recently completed a 5-year research project on sustainable sanitation involving the University of Ghana, the Ministry of Health, and the University of Copenhagen in Denmark. Ladies and gentlemen, please help me give a wonderful welcome to all of our panelists. And I think to kick us off, we probably want to start with a historical perspective. And so that would be Dr. Matthew Kavanaugh. For the next 5 to 8 minutes, Dr. Kavanaugh will tell us about what it is that we need to know about the history and the historical perspective in dealing with pandemics, vaccines, and kick the conversation forward. So Dr. Kavanaugh, you are most welcome.
Thank you, Dr. Dozian, and thank you so much for having me here. What a great panel assembled to talk about this issue, and what a diversity of folks. So I'm really excited for the conversation. So I think we could kind of start this conversation in numerous different places. I was actually thinking about kind of where to actually start. Do we start with, and the title of this talk about kind of post-colonial health makes me think, do we start in the kind of deep history of racial power, colonialism, and slavery that has resulted in wealth, that resulted in the ability of high-income countries to be able to very rapidly, when Chinese scientists put out the information about the genetic composition of COVID-19, to very rapidly invest billions and billions of dollars. I won't start there, but we could, right? And we should keep that context in mind as we think about kind of what's happened under the COVID-19 pandemic. Very immediately after the introduction of the world to the understanding in December that COVID-19 was a threat to the kind of outbreak that happened in China, we very quickly moved to the moment when Chinese scientists, as I said, working with the World Health Organization, distributed the genetic code for the coronavirus to the world. And that enabled scientists to immediately start standing up efforts to make vaccines and to think about the ways in which we could actually tackle, using biomedical interventions, this novel pandemic that was emerging. In particular, it's worth noting that high-income countries poured massive amounts of funds into this effort, including the United States, where, of course, our public health response was a rather massive failure, right? And instead of actually mounting a kind of effective public health response, the United States actually chose, at a federal level at least, to put almost all its eggs in the basket of Operation Warp Speed, to develop vaccines as quickly as possible. And in fact, massive amounts of funding was diverted to do so. And what we got out of that has been remarkable. Right? We've gotten multiple high quality, highly effective vaccines able to address COVID. These have come from public investment, right? So the United States put $2.7 billion behind, for example, the Moderna vaccine. The US paid 99%, in fact, over 99% of the Moderna vaccine. Dolly Parton put in $1 million. And so we've been trying to get her on the phone to see if she's up for sharing her part of that vaccine knowledge, since the US doesn't seem to be willing to do so. But this was a kind of public effort where, Dr. Barney Graham at the National Institutes of Health, he was the one who put together the package that was sent over to Moderna with the spike protein that's resulted in this vaccine that's in so many arms. You've got the Johnson & Johnson vaccine, also supported by the United States government. Europe paid for much of the Pfizer-BioNTech vaccine. AstraZeneca, created by Oxford, has been supported. So these are public goods. And yet we see deep inequality, right? So right now, the most recent numbers are that about 86% of vaccinations that have happened have been in high income and upper middle income countries, 0.1% in low income countries. And so the question we have to ask is why, right? There were declarations that there would be equity. The head of the European Union, Ursula von der Leyen, called them global public goods. I would agree, these are global public goods. And yet the actions of high income countries have been the exact opposite, right? So there's been an effort called COVAX, that the idea behind which was to say, we're gonna pool procurement, wealthy countries will put in money, we'll move this along. And yet that effort had two fundamental problems. One, it set a very low goal. The goal for 2020 is for low income and lower middle income countries to reach 20% of their populations. Now, here in the United States, I'm sitting in Washington, D.C., where it's just been decided that as of April 19th, every adult in Washington, D.C. will have access to this vaccine. What responsible head of state says in 2021, sorry, we're only going to do 20% of our populations? That's a recipe for a continuing pandemic outside of high-income countries. The other thing that, of course, happened is that the US and Europe bought up all the doses. And so this theory that we were going to have a COVAX facility that would equitably distribute was a little bit of a joke, right? Because here's a whole bunch of billions of dollars to buy vaccines, if you can get them, is a pretty cynical way to go about broad equity. And the core of this, though, was not just that the high-income countries have bought up all the vaccines, but that they've also limited supply, right? We've got this kind of massive global crisis when it comes to the supply of COVID vaccines, and it doesn't have to actually be this way. The reason why we've got a supply crisis is because it's been treated like a monopoly rather than a public good, right? And so we've been here before. We've seen this in HIV. For example, in HIV, we saw that 6 million people died in East and Southern Africa between the time that antiretrovirals were created and the time that they started to really be distributed. We have been here before, and that was because a handful of companies had a monopoly over the distribution. Activists, social movements, and doctors broke that monopoly. And the result is that today there's been a 99% reduction in the price of ARVs, and they are available to almost everybody who needs them. We could be doing the same thing. Right now, the newest HIV drug that recently came out, dolutegravir, was put out by ViiV. It came out with licenses to 5 Indian generic companies to make that medicine. It almost simultaneously resulted in access in the global south as in the global north. It is possible to do so. And yet we haven't seen it, right? Because there's the monopoly has been maintained on these COVID vaccines. This despite the fact that there is deep expertise in Africa, Asia, and Latin America. And if you're looking for manufacturers who know how to get quality, get quantity, do so at a low price, and distribute to low income countries, you want to be looking to these manufacturers, none of whom are currently freely making the vaccine as we know it. And so what do we do, right? 4 core things. 1, suspending TRIPS, which is the trade-related aspects of intellectual property agreement. It is been proposed by India and South Africa, and now almost well more than half of countries, more than 2/3 of countries have backed it now. A proposal that we simply pause the enforcement of intellectual property around the world when it comes to COVID-19. This gives countries a stick, right? And we can talk more about it if we want, but it gives countries the ability to say, look, companies that have these vaccines, if you don't share them, we're going to go ahead and make generic versions of them. But that is not enough, right? Because vaccines are not antiretrovirals. They're harder to make. There's a wide variety of complications there. What we need is also for high-income countries to use the leverage that they have over these companies. I'm living here in Washington, D.C. Our taxpayer dollars have paid for these innovations. We should be thinking about the ways in which we can use that leverage and that power to move things. The WHO in Costa Rica proposed something called the COVID Technology Access Pool. It would put all of the know-how and the pooling and the intellectual property into a pool and allow it to happen. And yet, cynically, high-income countries are just saying, no, our job is just to give money to COVAX. When in fact, the bottom line is what we need to do is to stand up manufacturing. And then my final point here is that we can stand up manufacturing because I've talked to manufacturers in Africa and Asia. It is possible within 6 months to stand up new technology. You can do it for about $500 million. And yet we're not doing so because there are substantive and legal monopolies. This, I think, is part of a long history in global health where Black and brown lives are judged less valuable than monopolies that get to be maintained. And so we need to learn from HIV that we can change the world and bring it into a conversation around COVID-19 vaccines. With that, I'll stop.
Thank you so much, Dr. Kavanaugh. So much to unpack there and so many questions. I'm so glad that you mentioned HIV so prominently, because now we're going to go to Dr. Hagen, who's going to talk to us about ACTs and trials and what we can learn from that and how we move forward. Dr. Hagen, please, you have the floor.
Thank you so much. Thank you, Dr. Dozian. And I'm really pleased to be part of this panel.
Frankie is good.
Oh, Frankie. Thank you, Frankie. It's very good to be here today. So I was asked to talk about the controversy that arose over the AZT trials in Africa in the 1990s. It's an interesting story. In 1994, the NIH AIDS Clinical Trial Group Protocol 076 showed that a long course of AZT, the generic name is zidovudine, reduced mother to child, I'm turning on my timer so I don't go over, reduced mother to child transmission of HIV infection by 2/3, from about 25% of babies being infected to around 8%. This long course regimen required women to start AZT in their second trimester and to take oral AZT 5 times per day. It also required intravenous administration of AZT during delivery, and newborns also received AZT 4 times a day for 6 weeks. Women who followed the regimen were also not allowed to breastfeed. In spite of all these obstacles to implementation, it was still considered to be a tremendous scientific breakthrough in the fight to prevent HIV and AIDS. However, this discovery meant very little to the majority of HIV positive pregnant women in the world, most of whom lived in low-income countries. The total cost of this long course AZT regimen was $1,000 per woman and child, and that's many times the per capita health expenditures of low-income countries at the time, which is around $10. In Uganda in the mid-1990s, for example, the per capita health expenditure was $3. Many births also occurred at home, and so it was impossible to deliver intravenous AZT at delivery. Additionally, many women did not seek prenatal care until much later, sometimes at the time when they were ready to deliver, and many women didn't have access to clean water to prepare formula, and they couldn't afford to purchase formula at any rate. So they needed to be able to breastfeed. So all in all, this long course 076 regimen was not feasible in the regions of the world where most of the births of HIV positive infants were occurring. So in 1994, this was the same year as the trial results were released, the WHO convened a meeting to discuss testing alternative regimens which would be more suitable to low resource settings. And it was decided that the best approach was to do randomized controlled trials of shorter and simpler courses of AZT versus placebo controls. So 16 new trials of short course AZT began in 1995, and all but one of them was placebo controlled. And these studies were conducted in Africa, Asia, and the Caribbean. 9 of these studies were funded by the United States NIH or the CDC. Now, because the safety and the efficacy of long course AZT AZT rather, had already been proven. The use of placebo controls sparked an intense debate, which began in 1997. That was 2 years after the trials all began. And what happened was Peter Lurie and Sidney Wolfe, a public citizen, they wrote a strongly worded criticism of these trials to Donna Shalala, who was the Secretary of Health and Human Services at the time, calling out the use of placebo controls as unethical. The rationale, though, from the United States and NIH and CDC in favor of a placebo arm was that the local standards of care were no treatment. An international debate over this research ethics surrounding this issue arose, and it focused on whether it was acceptable and ethical to propose a lower standard of care in research in low resource settings. Despite this debate, the trials went forward until 1998, when the placebo arms were dropped because the short course regimen was shown to reduce maternal child transmission by 50% in the Bangkok study. So at the time, everybody involved in this controversy would have agreed that it would be unethical to carry out a placebo-controlled study of AZT to prevent mother-to-child transmission in any high-income country like the United States, because placebo controls are not acceptable when a proven therapy exists. And we had that proven therapy from ACTG 076. The use of placebo controls, in fact, represented a lowering of ethical standards for poor countries, which in turn reflects a lack of concern for the welfare of people in those countries. So defenders of the placebo controls pointed out that the trials addressed questions that were relevant to settings where the 076 regimen was not possible, and that it was reasonable to search for a less effective, but still somewhat effective regimen. In other words, a lower standard of care and effectiveness was acceptable at the time. So the AZT controversy continues to be relevant to decision-making with respect to healthcare access in low resource settings. At the time, the editor of the New England Journal of Medicine compared it to the Tuskegee study of syphilis in African-American men, where care was denied. So we should be asking ourselves, should circumstances dictate our expectations of what constitutes acceptable COVID control in these settings? Are we not obligated to be conducting studies of ways to implement vaccine rollout in low resource settings? We all know that to stop this pandemic, we need to assure global rollout of vaccines that will protect against severe disease and death and may increase herd immunity. It will be necessary to assure allocation to places where they're needed and the infrastructure required to distribute them. At this stage, clearly more vaccine development needs to be tailored to the context of low-income countries with studies that include implementation designs. Thank you.
Thank you so very much, Dr. Hagen. So many ethical questions there. And I'm so glad that Dr. Liao is here to give us an ethical point of view from all that's been said and going forward. Dr. Liao, please, the floor is yours.
Thank you, Frankie. So rich countries are getting the vaccines, poor countries are not. What do we do about that? As an ethicist, I'm going to be looking at these issues from an ethical angle. And here are some of my thoughts. So there are some people in the world who think that, look, as long as they don't harm other people, they don't really have obligations to anybody else. Like the only obligations they have is to not harm other people. And those are, in philosophy, they're called libertarians. So, but not most people aren't libertarians. And unless one is a diehard libertarian, most people think, look, we have obligations to help those in developing countries to get to procure the much needed vaccines. So many people think that we have duties to protect and promote human rights and around the world. But even for diehard libertarians, there are good instrumental reasons why we should help those in developing countries in this way. So the COVID virus can mutate and make things worse for those in richer countries. The global economy is interdependent, and so on and so forth. So as I see it, the issue becomes not whether we have these obligations, but when and how we should discharge these obligations. So some people are of the view that each nation should take care of its own citizens first. And this has been called vaccine nationalism. So the idea here is something like, in an airplane emergency, we're told that we should give ourselves the oxygen mask before we try to help other people. So we should, in this case, also make sure that our citizens, family members, ourselves are vaccinated first before we try to help other people. There are others, though, who draw a distinction between urgency and need when deciding who should get the vaccines first. So all of us need a vaccine, but it's more urgent for some of us than others. So for instance, when the pandemic first broke out, many elderly who are being careful in nursing homes were dying, but it was very difficult for them to social distance. Likewise, frontline workers had no choice but to help patients with COVID. And in contrast, my family and I, we could isolate ourselves for months without too much hardship. So it was more urgent to help the elderly and the frontline workers than it is to help me and my family. So based on this distinction between urgency and need, some people believe that what we should do is try to prioritize urgent cases around the world as soon as possible. And in fact, this is roughly how COVAX plans to distribute 20% of the vaccines that it receives. But each nation also has its own share of the rich and the poor. So what is each nation's obligation to its poor, who also need the vaccines, but let us suppose not urgently? So funny enough, I tweeted the details of our panel a couple of days ago, and someone responded to my tweet with the following, and I'm just quoting. Here again, the conflict between us having to get vaccinated here, while the higher up, wealthier, already vaccinated people shout, give the vaccines away to developing countries. So the person here is making a plea that the poor in one's nation also has a right to be vaccinated. And so as a result, many nations' approach is therefore to offer vaccines to as many of their citizens as possible. But while richer nations are vaccinating one person per second, many poor nations have not even begun to vaccinate even one single citizen. So what can we do to speed up the vaccine distribution process to make it more equitable? And Dr. Kavanaugh touched on this particular point. Some nations such as India and South Africa have requested that the intellectual patents on vaccines be waived. But so far, the countries and pharmaceutical companies that have developed these vaccines are very reluctant to do this because they believe that this could stifle innovation in the future. So basically pharmaceutical companies might have less incentives they have to pour in millions of dollars to develop vaccines, and not all, it doesn't always succeed. And so they all have less incentive. They can't get the monopoly, they can't charge at the monopoly price. But more importantly, they also argue that the current bottleneck with respect to manufacturing and distribution of vaccines will remain. So even if you waive the patents, you still need to up the manufacturing capacities. So a different proposal calls for making sure that programs such as COVAX have enough funding so that they can purchase enough vaccines on behalf of the developing countries. The US has pledged about $4 billion to COVAX, while, for example, the UK has pledged about $500 million. But it's estimated that COVAX needs to raise an additional $6.8 billion just this year alone. So a third proposal calls on nations that have surplus vaccines to donate their surplus as soon as possible. So President Biden has loaned AstraZeneca to Mexico and Canada. And he announced 2 days ago that the US is, and I quote, going to start giving the vaccine around the world to poorer countries because you can't build a fence high enough. You can't build a wall high enough against the virus. And my all brief take is that pharmaceutical companies should right now try to build more local manufacturing capacities of the various components of a vaccine, even if they don't want to give up the patents, because they're, the vaccines have different components and they can at least outsource some of them and begin to build them at locally at different communities. And this way, the vaccines can be made and distributed more quickly. And this is going to require financial resources, not just from richer nations, but I also think pharmaceutical companies have an obligation to do this, as well as individuals. Thank you.
Thank you so much, Dr. Liao. Thank you very much for that. Professor Kojo Senna, you are in sub-Saharan Africa. You are in Ghana, which has a history of excellent vaccinations, or at least very good vaccinations. What is your take sociologically on all of this?
Right. Good evening to you all, and or good afternoon to you. It's 5:30 here in Ghana. The weather is pretty dark because it's going to rain. Yes, I guess it's sunlight where you are. I can see the background of the chicken. It's really beautiful there. Right, coming from this side of the Atlantic, I have a lot of stories to tell, but I don't know whether I can tell all these within 5 minutes. I'll try. Yes, to start with, I guess there are many people who don't know Ghana. Oftentimes in my interactions with Americans and Europeans, when I mention that I'm from Ghana, they often think I am from Guyana. Ghana is in West Africa. Indeed, it's in the middle of West Africa. If you take a look at the map of West Africa, it's there. Ghana, like most developing countries, has been a colonial state of Britain, and so our infrastructure, our commerce, our economic activities, all these have been shaped, more or less to harmonize with the post-colonial system. To move forward or fast forward, talking about COVID. Indeed, towards the end of 2020, we heard of COVID. And the Ghanaians were of the opinion that, well, we've heard of SARS. There was no SARS in Ghana. We heard of MERS. There was no MERS. 2014, there was COVID. There was Ebola in the Mano region of West Africa. We managed to escape. So this time around, we are likely to escape COVID. Unfortunately, we didn't. And early in the year, we had our first 2 cases of COVID from people who were coming in. And this is very important because the general belief of Ghanaians is that the whole COVID crisis in Ghana started with those Ghanaians and people who lived outside and decided to come into the country. So our understanding is that COVID is an external disease, or people brought it from outside, and therefore we should stop people from entering the country. Of course, the government has been battling with this issue. If you stop people from coming into the country, you also have to think of the economic aspect of it. Over the months, there have been all kinds of measures. We have had lockdowns, partial lockdowns, schools have been closed, churches have been forced to cut down on their celebrations, funeral parties have been banned, or perhaps the numbers of mourners have reduced considerably, and all kinds of measures. But the issue then is how are we as a people responding to this? Now, I started by saying that in Ghana, first of all, we began by thinking that COVID would not come in. And so there was no preparation for anything. In fact, we had a good opportunity to prepare for incidents like this when Ebola struck in the Mano region, Ghana, Guinea, Liberia, and Sierra Leone. Unfortunately, structures were put up, but then when Ebola incidents reduced considerably, we dismantled all those structures. And so COVID caught us more or less, pants down. Now, so while Ghanaians have been crying and hoping that there will be a vaccine or a cure for this condition, we were very happy when all of a sudden we were told that, well, now we have vaccines around, AstraZeneca and the rest. And so everybody more or less hurried. But then the issue was, or others were asking, How come that within this short period, vaccines were produced? We've been dealing with malaria for years, and there's still no vaccine for malaria. We've been dealing with other parasitic and infectious diseases for years, and there have been no vaccines for this. How come that we now have vaccines for COVID? And then the conspiracy theories came in. Oh, you know what? These Europeans, Americans, we shouldn't trust them. We shouldn't trust them. Yes, there has been conspiracy theories to eliminate the Black population. Do you remember what happened with the contraceptives, etc.? Indeed, Melinda Gates, the Gates' wife, was reported to have said that, oh, with COVID-19, people would die in Africa like maybe chicken. Fortunately, this came to pass. And today, Ghana, like many other African countries, have very low or have been able to manage the COVID cases. Since 24th March of this year, we have had no COVID deaths. Our death toll for the entire COVID situation is 740. We have new recorded cases of 121. We have active cases of 1,451. We have total confirmed cases, or we've had total confirmed cases of 90,287, out of which 87,137 have recovered. And of course, as I said before, we have 740 deaths. Of course, these statistics may look impressive, but given the Ghanaian situation, it is possible that there are a number of cases that go into the dark figure. People who die in the villages don't get reported. We know of the Muslim communities where if somebody dies within 24 hours, the person is buried. So that does not factor, or these don't factor into the mortality statistics. But by and large, dealing with COVID, this is where we are. So our response has been varied. There are people who believe that COVID does not exist. If it does, it is from outside. There are people who say, well, it exists, so let us follow the protocols. And there are people who are saying, no, the protocols are still stringent. In Ghana, like in many African countries, life and livelihood are the issues. What do I eat when there is a lockdown? Where do I have water to drink if there is a lockdown? Because we don't have home pipes, People sometimes may have to travel several kilometers to go and fetch water. So if there's a lockdown, how do they deal with this situation? So government, during the lockdown, government decided to distribute foodstuffs to people. And indeed, the foodstuffs cost more. It became a super spreader because people disregarded all the protocols and, began to hanker for food. In fact, survival, as we all know, is the first law of nature, So people were really running around looking for food. And therefore, people didn't care about COVID protocols. Church activities are one big problem in this country, Ghana. We are a very highly religious nation, like Chike's Nigeria, And so whatever we do, we have to factor in the religious aspect. Now, there are religious leaders in this country who are also part of the conspiracy theory. They say, God saved us from Ebola. God saved us from SARS. God saved us from MERS. And so God will save us from COVID. There are religious leaders who are also saying that God said, or it has been said in the Holy Bible, that for lack of knowledge, my people perished. Yes, God has given us the brains to develop systems to address threats to our health. So these pastors are saying, well, the COVID vaccines are an answer to the problem that we have. And so they are telling their congregations to go and take the jab. The congregation is divided. There are those who are going for the jab. There are those who refuse to go for the jab. We took our first 600,000 doses a few months ago, I think early March. And initially, the response was very slow. There were people who stood back to watch. Let's wait and see what will happen to those who will go in. A number of people went in, and rather fortunately, not many people complain of terrible effects, except for the pain that one experienced from the jab point and all that. Otherwise, we haven't had any serious problem with the COVID vaccine, AstraZeneca to be precise. So in Ghana, we are also lucky that it's only the few people, the few elite in the urban areas who argue a lot about COVID. But otherwise, for the generality of Ghanaians, the problem is where to find food to eat. And if there's a jab, how do I get a jab so that I can survive? As to what is happening in Europe, or people are saying AstraZeneca causes blood clot and all that, not many people are listening to that. Bring us the jab, we'll take the jab. For us, survival is very, very important. And so all the issues going on in Europe, as to, vaccine grab, vaccine greediness, and all that we are saying is government, find the money and bring us the vaccines. Those who want to take, will take. But it looks like from recent surveys, the majority of Ghanaians want to have the jab. So far, this is where we are. Let me quickly bring in our traditional healers. Our traditional healers have also been doing something. A few of them have come up to say, well, we have developed herbal medications that may address the vaccine issue. We have a center called the Center for Research into Plant Medicine. It's a government institution, the WHO recognized. And so this center takes care of these things. So some of the healers have sent their herbal medicines to that center to be examined, to test for their efficacy, toxicity, and what have you. Indeed, what is happening in Ghana also is that COVID has taken all our attention. So nobody is now talking about HIV/AIDS. Nobody is talking about, the other diseases. As a developing country, we have a epidemiological transition where we have these traditional diseases existing side by side with modern day diseases like diabetes and the cancers and what have you. But as a result of COVID, nobody is talking about this anymore. And of course, understandably, government is focused on finding the money to get the vaccines in. But one of the good things that has come as a result of this vaccine is that Ghana is now thinking of teaming up with all the African countries, to develop vaccine infrastructure. We do not have to wait like a normal, typical colonial country to depend on the colonial power for vaccines. We are now asking ourselves, why come that after 60 odd years of independence, we still have not been able to develop infrastructure to be able to deal with epidemics like this? And that we have to wait for AstraZeneca, for Moderna, and the rest to come before we start moving. So this has taught us a lesson. Indeed, government has promised that in each of the 16 regions, it is going to build a facility. I don't know whether that is a political talk, but government has promised the nation that is going to build in each of the 16 regions a health facility that will take care or that respond to any pandemic in the future. And for me, I think this is good because for a long, long time, we have not been very serious with our health system. We have not been very serious. We depend on people and on Christian missionaries, to provide healthcare to the people. Government itself knows that providing healthcare for the people is a public good. Government understands that perfectly well. But government will tell you that we don't have the money to build or to build a very good health system. Now we are being pushed as a result of COVID to do all this. And so for me, this is good. As the Chinese say, out of every crisis, there is an opportunity. And the opportunity for us to develop our own vaccine infrastructure, opportunity to address our common health problems, opportunity to educate people, opportunity to allow people or to enable people to survive. That is our mantra for now. So let me rest my case here and wait for the cue.
Thank you very, very much, Kojo. Much appreciated. You raised a lot of issues. And one of the things that was very interesting to me is you were talking about the government now saying, where do we get money to do this and to do other things? And I wondered if Dr. Kavanaugh, you could jump in here and just touch a little bit on, you mentioned, why do you think the COVAX goal was so low?
Mm-hmm.
No, it's a great question. And I think it's a tyranny of low expectations. You know, I think many of us, when the pandemic hit, looked at that and said, what do you mean 20%? Why would we set it that way? So I think there's kind of two different pieces. One, you know, they looked realistically and said, there's no way we're going to be able to buy enough vaccines. We're not going to get enough money. We're not going to be able to have access to enough. So therefore we should set a low, you know, a low goal. And that's the way we should do it. But I think the bigger point here is that, you know, what we needed and what we still need is a strategy that thinks about using the technologies we currently have to actually end the pandemic, right? These are remarkable, especially the mRNA vaccines that have been created are just these remarkable breakthroughs. And in fact, this technology is going to be used for malaria. People are talking about using it for HIV. There's any number of ways in which this technology is going to get used. It's really good. And one of the things that it's really proving is that it is stopping transmission, which means if we are smart, if we right tomorrow want to stop this pandemic, we could make low cost, high quality versions of these. The mRNA vaccines are especially good because you can actually stand them up quickly. They're easy to make. They actually, compared to, you know, traditional vaccines, that's the whole design. That's why the National Institutes of Health was just so dedicated to making it happen. And yet, the expectation from the global health is that we would only do 20% for low-income countries. And I think that that's just a tyranny of low expectations, right? It's instead of saying, let's actually treat some sort of global equity, instead it was, well, eventually at the end of the queue will come Africa, Asia, and Latin America. And I think that's a huge problem. And I think global health actually needs to confront that real challenge and that real expectation. I've had several conversations with, you know, African leaders, including, you know, colleagues from the African CDC, from a number of health ministries, who all say, what your Ministry of Health would never have accepted a strategy, you know, of doing 20%. Why would you expect us to do so? And so I think it is something that was cooked up in Geneva and Washington that doesn't actually kind of respond to the needs that exist around the world. And that's about politics and power and a long history.
Thank you. Thank you so very much. Dr. Hagen, I wondered if you could jump in here, because now we look at low expectations. And if you can tell me, in your take, in the minutes that we have, what was the biggest lesson that we could learn from the HIV crisis and the HIV trials that we could now apply to COVID-19 for developing countries? You're muted.
Thank you. So thanks for asking that question. I really liked something that Dr. Senna said, which is about the fact that African nations are coming together to develop their own infrastructure and their own plans for implementation. I mean, I think that it's not for us to set the expectations for other countries. That is the main message. And every time that we do so, you know, it leads to heartache and disappointment and failure. And so I appreciate the question, and I just have to reemphasize that, you know, the expectations really need to be determined locally. Communities should be able to, you know, have some self-determination around what they're going to do around COVID. And people in Africa and other low-income countries, they know best. They know much better than we do how to mount some of these implementation strategies.
That's just wonderful. Thank you. Thank you so much. Dr. Liao, I was thinking about something that you said in terms of ethics. So you did mention that President Biden has given, I think, Mexico and Canada AstraZeneca. And I wondered if you could just touch a little bit on the ethics of giving vaccines that you have not approved for use by your own people. I think you mentioned talking about how countries are taking care of their own people first, but in the United States, you cannot use AstraZeneca. But why is President Biden giving something that has not been proven worthy of use in his own country to other countries? Can you touch a little bit on that, please?
Yeah, that's a wonderful question. I had that thought as well, as sort of why is President Biden giving AstraZeneca and not other things? I take it it's more politically acceptable that he did it for political reasons. There are all these other vaccines and they're already being used. AstraZeneca's, I guess, they're trying to figure out whether they should approve it. It's been approved in other countries, but there's the blood clotting problem right now that it looks like there's some evidence that it's causal, although it's very small risk. And so just all things considered, it was clear that the US was not going to use, most likely not going to use AstraZeneca's drug because they had all these other vaccines available. And so that was something that they could easily, right now, they had these supplies and they're just sitting there. And so they thought, well, if we're not going to use them, and if somebody's willing to use them, let's at least make good use of them, by loaning them. So I think that's the thinking. So,
okay, thank you so much for clearing that up. We do have a little bit of time, and I want to just jump into questions from those who are listening to us. And this first one, I think it's a general question, but I will direct it to Professor Senna, and then the rest of us can touch on that in 30 seconds. And the question is from a person named Lena Benson, which says, why is there such an eagerness to test the vaccine in poor countries? But then when it comes to rollout, we aren't willing to give access.
Well, that's a very wonderful question. This question has come up several times. It's simply, for me, it's simply an extension of the neo-colonial relationship. We are used to test vaccines, and when it comes to rolling out, we are the last to get it. So that's why Africa is now asking itself, what should we do to ourselves or for ourselves? So that is my answer. It is, for me, an extension of the neo-colonial relationship, and we have to break it up.
Thank you, Kojo. Does anybody else want to take a stab at that? Or should we move on?
I mean, just to reinforce, I think that's right. I mean, I think, we in global health writ large, there's a real sense that that innovation happens in the North and it will slowly trickle down to the South, and that slowly trickling down is fine, which is neither factually true nor ethical, right? I mean, and I think this kind of understanding of kind of where do these relationships come from and the ways in which wealth flows are really important to pay attention to, but also the ways in which ideas flow. And the idea that somehow the fact that the United States, because it had the funding to be able to put into the NIH to be able to create the vaccines, should then somehow exercise the monopoly over how those vaccines are produced, who gets them, et cetera. I mean, what's remarkable right now is actually, I can't think of a time in history where we've done this kind of level of allowing a handful of private sector actors to determine our ethical allocations. We're having lots of conversations around the idea of ethical allocations, but globally, it's up to Moderna who gets Moderna's vaccine, and up to Pfizer, where it's going to ship the money. And frankly, it's up to AstraZeneca, where the Serum Institute in India ships its vaccines, which is why they're shipping them from India to Canada. And so we have outsourced the kind of ethical conversations when it comes to globally that we would never allow domestically. And I think that's a huge, huge problem.
Thank you so much. There's another question that's come in, which we haven't really touched on. And this is from Douglas Magison. And the question is, how did the Sinovac and Sputnik 5 fit into the world calculus of immunization? Anybody, just jump in.
Thank you.
I'll just say, at the risk of, I think it's really interesting, right? Because here you've got, Sputnik 5 developed by the Russian company with a bunch of backing from the Russian government, that's actually had peer-reviewed public information showing that it works, right? Gimlea is actually the only company in the world right now that I know of that is actually doing this. They're actually technology transfer. So they're making it in Morocco and they're letting the Moroccan company decide where it's going to go. They're making it in Egypt, I believe, and deciding where it's going to go. And so that is the only company that's actually licensing. And so I think it is really interesting. It is resulting in a crisis. The Biden administration just now appointed somebody at the State Department whose job is full-time to think about vaccine diplomacy, because what they're understanding is that especially middle-income countries around the world are uninterested in donations as a structure for public goods, and instead are actually looking for support to create, as Dr. Senna was saying, to stand up manufacturing capacity so that it's about a coordinated relationship and a cooperative relationship, not donations. I think they're finally realizing that this is very bad diplomacy, that actually the Chinese and the Russians are eating the US alive when it comes to global health right now, and that's a problem.
Okay, and so we do have another question, and it says, is it reasonable of me to distrust and evade the RNA technology because there have not been long-range observations of the vaccinated persons for unintended consequences? Dr. Hagen, do you want to take a stab at this?
Ooh, I wish I knew the answer. Yeah, that's, I mean, I don't feel like I have the background to answer that. I can only really cite what I've read by other people, but I'm going to punt this one to Dr. Kavanaugh. Maybe he has an answer.
Dr. Kavanaugh, Dr. Liao,
Do you have an answer?
any of you want to take a stab at that?
Yeah, I think the bottom line is no, it's not reasonable to worry, right? But it is reasonable to ask the questions, right? So I mean, reasonable is the wrong answer. Folks should not be worried, but they should ask the question. Here's what's worth knowing. The mRNA technologies have been in development for years, right? And so while it seems like we've actually all kind of done this all of a sudden, what essentially is true is that these are vaccines that have been piloted over years and years and years. The technology has been in development and they were at the end stages. Frankly, the Moderna vaccine was originally a MERS vaccine, and then MERS disappeared, right? And so all of a sudden they could no longer continue, right? But they had gotten all the way up to the place where there was no longer the ability to do trials because the disease had disappeared. They changed one little thing in it, and they changed the spike protein, and they made it into a new vaccine, and that they were able to put into trials. I think, look, you've got options, go out and get the best one, but I have to say that the mRNA technology is almost certainly going to be what sweeps the world in the near term for kind of new, innovative, powerful technology, and it is pretty well tested, so yeah.
Oh, thank you so much. We've got about 4 minutes, and I want to get in at least one last question. And this one says, once the vaccine is made available to poorer countries, hopefully soon, what is the estimate of vaccine hesitancy in the populations compared to the US and Europe? Dr. Senna, that sounds like something that you should tackle.
Yes, I've just been thinking through. Unfortunately, we haven't done serious studies on vaccine hesitancy, but just from casual observation, people are really hesitant. They're asking the question, is this safe? How come that within a year, the vaccine has been developed? And why is it coming from the north? Why are we unable to develop the vaccine for ourselves? All kinds of questions are coming in, and of course, all these are coalescing into vaccine hesitancy. I don't have an answer for this, but all I can say is that yes, in Ghana, there is a large number of people who simply don't want to take the vaccine, either because they don't trust its efficacy, they don't trust what will happen after they've taken the jab, or simply because of religious reasons. God will take care of us. That's what they say.
One thing, I'm sorry if
Yes.
I can, one thing that Dr. Senna said that I thought was really interesting is that the sources of vaccine hesitancy are very different in Ghana than they are in what I've read about from the United States and Europe. And so, I mean, I think that this goes to answer this question from a public health international student who's seeking to gain skills to bring in expertise back to their home country. As someone who's been doing research in public health and working on prevention programs for a long time, 30 years. I'm more and more convinced that community engaged research is really more likely to produce results that are both relevant to the community and have greater impact. And it's no longer about publications. For me, it's about public health impact. So that would be my little bit of advice that I could offer up.
Thank you so very much, Dr. Hagen. You actually will have the last word. So Dr. Hagen, Dr. Senna, Dr. Kavanaugh, Dr. Liao, thank you so very much for joining us. And a huge thanks to NYU DC, the Bradamar Center, and the NYU Global Public Health School for putting this conversation together. I've learned a lot. And I just a little housekeeping to know that anyone who wants to see this again, there will be a recording available. So thank you so much, scholars and professors, for joining us. You have my thanks.